admins. So I was busy sorting that out. I'm so sorry for the delay. I believe let's start this today's session, right? So
Yes, yes.
okay, I'll just introduce you to my team members. When we started IVF, there was a time when we used to subject a lady to multiple blood tests to detect a LH surge, and then we started with laparoscopic ovum pickups. Then the era had come when we used agonist protocols, and now the time have come where most of the infertility specialists have switched over to antagonist protocol with the freeze all technique. So whatever comes with a question as well. So in our medical field now, when we in Indra especially, we are doing more than 95% frozen embryo transfers. So the need of the hour was that whether frozen embryo transfer was totally safe or not. But the latest upcoming studies have come up that in hormone replacement cycles with FET, the ladies are prone for hypertensive disorders in their pregnancies. So to address that issue and how we should combat this complication arising out of hormone replacement of frozen embryo transfer cycles, I invite you with us for this session. And I will take the privilege to introduce Dr. Christophe Blockeel, who is MD, PhD, Medical Director of the Center for Reproductive Medicine at University Hospital Brussels in Belgium. He is the President of the Belgian Society for Reproductive Medicine. Over to you, Dr. Christophe. Just enlighten us on this very topic, please.
So thanking you so much for this kind introduction, the kind words, and also the possibility to share with you some data about natural cycle IVF and the frozen embryo transfer cycles as we all do them. So if I recall well, and if everything is fine now, then the screen should be shared. Do you see my?
Yeah, we can see your screen, doctor.
Okay, so this is fine. So how to prepare a frozen embryo transfer cycle? Well, if I can give you a oh, small introduction, then so we are going to talk about frozen embryo transfer. We're going to talk about the synchrony between the embryo and the endometrium. First of all, the question is when to perform a frozen embryo transfer. Immediately, or should it be delayed after an antagonist protocol? And then how can we prepare our endometrium with, of course, the major accent to the natural cycle frozen embryo transfer? And we will look at some outcomes and at some extremely recent literature of the last few days. Now, first of all, if we look into the data of the SARTs of the American Society, then we see that there is more or less a standstill with regards to the outcomes in fresh embryo transfer cycles. But what we see is that there's actually an extreme increase in terms of live birth rates with regard to the frozen embryo transfer cycle. And this is maybe because of the cycle segmentation, and we do more PGT, we do more freeze-all strategy because of several reasons. Most important reason is, of course, ovarian hyperstimulation syndrome, also the late follicular phase, elevated progesterone that we see, and an asynchrony between embryo and endometrium. Now, probably the major point or the major issue in terms of increasing live birth rates after frozen embryo transfers is, of course, because of the vitrification program. And if I recall well, you guys in India were very well understood this, because more and more, and you were actually one of the first to do the freeze-all and the vitrification process in the vast majority of your patients. We need to say that in Belgium, for example, in our center, only 29 to 30% of the cycles are freeze-all cycles. You guys, you do in the vast majority of the cycles, freeze-all cycles. So you do have a lot of experience with frozen embryo transfers and with vitrification. So this is the survival rates that we observe until 98% of survival post-warming. Now, if we look into the embryo and into the endometrium, so this is the major point. What we want is to implant our embryo in a receptive endometrium. Now, what is then the best period to implant? Well, we are still using the definition of many years ago of the WOI, the window of implantation, the period during which the uterus is receptive for implantation of the embryo or blastocyst, which is more or less between, so LH plus 6, 7 until LH plus 10. So this window of implantation remains a real question mark, because there is a lot of discussion whether, you know, the ERA test, whether this window of implantation is really so narrow, because many studies have shown that actually when we look into receptivity of endometria and a varying number of days, that the receptivity remains high. So we need to be very cautious with the endometrial receptivity array test. With the ERA test, there is now a study in revision in RBM Online, so not in Nature, not in the Lancet, not in Human Reproduction, but in RBM Online, Reproductive Biomedicine Online, of the large RCT of the ERA test. So we will see whether this ERA is really the holy grail or not. So with regard to the natural conception, of course, we know that the embryo and endometrium have a nice synchrony, but of course the asynchrony will be created in this situation when we have an ovarian stimulation, when we have an advancement of the endometrium, and this is what we should correct. And of course, one of the possibilities to circumvent this is to do a freeze-all strategy. But now what we did in our center was a first study looking at when to perform our frozen embryo transfer, because you have undergone an, let's say, a time-consuming, an expensive, a burdensome treatment of IVF. Can we immediately start a frozen embryo transfer following a freeze-all protocol? So we divided our patients into group A, patients who started bleeding, and you know that after an oocyte retrieval following agonist trigger, that patients will start bleeding 5, 6, or 7 days after the oocyte retrieval, and they started immediately. Whereas in group B, the patients did not want to start, or the physician told them not to start, and there was a delay of at least 1 menstrual period. And the results were quite striking, because we did that study together with our colleagues from Vietnam, Dr. Lan, and actually what we observed was a borderline significant higher implantation rate and ongoing pregnancy rate when we performed the embryo transfer immediately. So telling our patients after an ovarian stimulation that they should rest, that it has been tough, that the ovaries should calm down a little bit during at least 1 month is probably nonsense, because we observe in the blue bars higher ongoing pregnancy rates with patients who started immediately. This study was confirmed by another Spanish study who also looked into freeze-all cycles, again retrospective, freeze-all cycles, where patients started immediately versus after 1 or 2 cycles. And here also same observations with a non-significant higher pregnancy rate when there was no delay. So this is very important because the time to pregnancy, you know that patients want to become pregnant tomorrow. Well, if we do a freeze-all cycle, we do not need this 1 cycle of rest before we can start our frozen embryo transfer cycle. Now, how can we prepare our frozen embryo transfer cycle? Well, there is, of course, a lot of possibilities. We can use a natural cycle, but then, of course, we need to agree upon the fact what is a natural cycle. A natural cycle is a natural cycle, awaiting the LH peak and no luteal phase support. This is a natural cycle. Or are we talking about a modified natural cycle? And then with regard to the modified natural cycle, there is also a lot of definitions, because modified could mean that we trigger with HCG. Modified could mean that we foresee luteal phase support, or that we could include both the trigger and both the luteal phase support. So we need to agree upon a nice and uniform definition what modified natural cycle means. We have ovulation induction cycles with clomiphene, with letrozole as a first choice, I would say, and then with gonadotropins. And then we have the HRT cycle that is still today mostly used. In the whole world, probably 80% of the frozen embryo transfer cycles will be prepared in an artificial way using micronized estradiol or estradiol valerate. When we do a comparison in this nice Cochrane database of systematic reviews with regards to the one preparation versus another, the natural cycle versus an artificially prepared cycle with or without agonist or a modified natural cycle, then actually there is no evidence that there is a protocol superior towards another. So actually, in terms of outcome, it will not be really different. So this is the most widely used protocol for a FRET, for a frozen embryo transfer cycle. It's the HRT cycle. And of course, the reason is obvious. The scheduling, the programming, the planning is much more easy with our artificially prepared cycle as compared with the natural cycle. But recently, and I'm talking about a couple of months ago, there was this von Versenhoink paper that showed us that there might be an issue. As was already pointed out during the introduction, it seems that the hypertensive disorders and other complications like preeclampsia and severe preeclampsia turned out to be higher prevalent in an artificially prepared cycle as compared with a spontaneous cycle or a FRET natural cycle. And of course, this is extremely important. And I am proud to say that at ESHRE, there was just an oral communication that was accepted by ESHRE this year in 2020. It will be a virtual ESHRE this year, where we observe the same issue in our cohort of patients. So indeed, an increased preeclampsia in patients with undergoing an HRT cycle. So we need to ask ourselves questions. Can we proceed with this artificially prepared cycle, or should we maybe have more data before we need to bury this frozen embryo transfer in an artificially prepared cycle? Because we are also thinking in terms of maybe it is because of the relaxin that is present in the corpus luteum. So couldn't we add relaxin to our patients? Would that be enough? Or should we maybe go back to the natural or modified natural cycle to prepare our endometrium? So this is, of course, the subject of today, the natural and the modified natural cycles to prepare the endometrium in a frozen embryo transfer cycle. What is important? Well, important to know that in a natural cycle, the endometrial development is caused by endogenous hormonal production of the ovary. And then the time of ovulation can be checked. We can check it in the blood, we can check it in the urine, and it has been defined as an increase of more than 80% of the mean level in the previous 24 hours. You know that some of us, we distinguish the time of ovulation not really as measurement of LH, because you are never 100% sure whether it is the upper leg or the other leg of the LH that you are measuring. So then you could also measure progesterone. As soon as the progesterone turns out to be 1.5 nanogram per ml or higher, you can assume that your patient has ovulate. Or, as said before, we can also trigger by HCG, and that offers, of course, more possibilities to schedule. But when going back to 2010, when Human Fatemi, who works in Abu Dhabi now, he used to work in Brussels with us, he did a study, a randomized study, and he compared two groups, spontaneous LH, frozen embryo transfers, versus HCG triggered frozen embryo transfers. And the study was interrupted after 120 patients included, because look at the ongoing pregnancy rates. Ongoing pregnancy rates were 14% in HCG group and 31% in the spontaneous LH group. So we said there is a major problem here. Probably the HCG that we give is also causing an advantage of the endometrium. Maybe we should completely stop our administration of HCG. And Dr. Weissman from Israel, he said, no, I don't believe you guys. Probably the planning, the way how you transfer, or the way when you transfer is maybe not correct, because we are talking here, it was 2010, about day 3 embryo transfer. And we transferred, as soon as we had an LH, our embryo, day 3 embryo, after 5 days. We transferred our embryo in the HCG group also after 5 days. But Weissman said, no, you need to do it in a different way. You need to do this. If you are talking about LH search, so the blue, LH search, then you plan your day 3 embryo transfer 5 days later. Well, why is that? Well, if you have an LH peak, it means that your so-called time for oocyte retrieval would be 1 day later. And then the 3rd day, you do the warming of the embryo, because we in Brussels need to say that we do the warming of the embryo in day 3 only, the day before the transfer. So it is as if we transfer our embryo on day 4, a day 4 embryo in a day 4 endometrium. So that's why we come to day 5, sorry. And this is probably the most important slide of the whole presentation. If we do a day 5 embryo transfer, a blastocyst transfer, we plan it 6 days after the LH peak. Why? Because if you do the LH peak, then you do the pickup, or the so-called pickup, the virtual pickup virtual oocyte retrieval 1 day later, then we are talking about the blastocyst. So 1, 2, 3, 4, 5. So 6 days after the virtual oocyte retrieval, you do the thawing, and in day 5 we do the thawing and the transfer the same day. You have seen with day 3 we do it the day after. So this is how we do it. But if we give HCG, if we administer the Ovitrel, if we administer the recombinant or the human HCG, then it is different, because there is a delay, of course, in the, there is a delay of the HCG peak, of the LH peak. So it is as if you would do the oocyte retrieval after 2 days. So we need to postpone 1 day. So this is maybe why Fatemi had so low pregnancy rates in the HCG, because he did the transfer here on TOR+3 and for day 5 here, and that was maybe too early. So based on this graph, based on the comments that we got from Weissman, based on the very bad results of human Fatemi, we looked into the new results after the time we changed the policy, and that was from 2012 onwards. And this publication, where I'm proud to be the last author in human reproduction, a colleague of mine, Marie Montagu, who is a French colleague who used to work with us, she scrutinized the whole story of the natural cycle in a retrospective way. And if you can look at the clinical pregnancy rates in a modified natural cycle plus luteal phase support versus the natural cycle and luteal phase support and a complete natural cycle. So we scrutinized 3 groups. So HCG plus utrogestan, no HCG, so awaiting the spontaneous LH peak and utrogestan, and then a complete natural cycle without any medication, just endocrine monitoring, just monitoring visit of ultrasounds and blood samples, no medication, no micronized vaginal progesterone, no HCG. The observation was that the higher pregnancy rate was observed in the complete natural cycle. So actually, again, the lower outcomes came from the HCG triggered plus luteal phase support. And we were puzzled, of course, to see the difference between with and without utrogestan. We were really looking at these data, and based on these data, we changed again the policy and started luteal phase support, not the day following LH peak, but on the day of embryo transfer. Because if we are talking about patients with, luteal phase insufficiency, this probably means that we need to add progesterone later in the mid-luteal phase and not immediately after the LH peak. Because of course it was easy. Oh yes, dear patient, you have an LH peak, you can start with your micronized vaginal progesterone tomorrow. No, that's too early, because the progesterone rise is of course much slower. So this is why we changed into giving progesterone few days later and starting on the day of embryo transfer. There is also a manuscript under preparation that we are looking at now. It's actually a complete natural cycle versus managed natural cycle in this new way of planning. So it is natural cycle plus 5 days versus managed natural cycle plus 6 days. And there we do not see the difference. So in the retrospective analysis, there was a small non-significant difference. Now we do not observe this difference anymore. And it has now been accepted, the study in human reproduction. So important to know that if you plan a natural cycle frozen embryo transfer of a day 3 embryo, that we thought the day before and replace the next day, that it will be +5 days. If we do the modified natural cycle using HCG, then we do it +6 days. So this is the major point that maybe we should take into account. It is true that we still need progesterone supplementation in our patients, and probably, of course, in the patients who have luteal phase defects. We are talking about less than 10% of patients who have the luteal phase defect, but this is very important to listen to the patients with regard to the medical history. How long is the cycle? What about the follicular phase, luteal phase, and so on? So this is important to know. But what we observe today is that there will be no significant difference between a true natural cycle and a modified natural cycle. So important issues to know. So when to start? Of course, there is a bit of a lack of data, and maybe, and this is also an invitation to you. I know that you do a lot of cycles in Indra, so it would be nice to do some prospective studies together. I think that if we could revive the frozen embryo transfer in a natural cycle, it would be extremely interesting to do some nice, well-designed and large randomized control trials together. What is the advantage? Well, the advantage of a natural cycle is, of course, in the hands of the patients. They do not need to take medication. But of course, we need more ultrasound scans and blood samples. We need more endocrine monitoring in terms of having less cancellation risks, because per definition, there will be a higher risk of cancellation. We have less flexibility. If we go to France, where it is impossible to transfer on a Sunday, for example, well, you have less flexibility. Then how are we going to circumvent this? Well, again, there, the French people have some solutions, but maybe not ideal. This is what I wanted to show you. What about adding other agents for ovulation induction? We are talking about natural cycle versus clomiphene cycle. Study from Kiro, retrospective, large study, but showing no difference when we add clomiphene citrate versus nothing. You know that in Europe, in most of the countries, letrozole is off-label, so you will see very small number of studies with letrozole in frozen embryo transfer cycles, unfortunately. Then with regard to HMG natural cycle versus clomiphene and HMG, an old study did not show any differences. What I wanted to show you is this a recent study that came out a couple of days ago. And STC means a stimulated cycle versus the modified natural cycle. And modified natural cycle was defined as luteal phase support. So the difference in this randomized controlled study in 120 patients involved, 60 versus 60, was quite easy. They gave FSH in the follicular phase from day 6 onwards, and then they did one scan, one blood sample to see if the patients were ready, and then they awaited spontaneous LH peak and measured the progesterone. In the natural cycle, they did the same without FSH, so again awaiting the spontaneous LH peak and progesterone rise, and then provided luteal phase support. Both study arms were completely similar in terms of ongoing pregnancy rates and live birth rates, but in the modified natural cycle, we observed more monitoring visits. So the patients needed to come more frequently to the clinic. But of course, in their discussion, they state that probably if the patients do not want injections, if they are reluctant to have injections, then this modified natural cycle could certainly be an option. A nice but small randomized control trial that was published a couple of days ago. So what we propose is that if you have no possibility of doing your embryo transfer on a daily basis, then probably the HRT cycle is still the cycle of first choice for your patients. Where I can also give you, it's a presentation on its own. So if you want more slides on the HRT cycle or the planning of the HRT cycle, I can provide you. But if I recall well, it is not the subject of today. If we do the modified natural cycle with HCG trigger, then talking about blastocysts, we give HCG and we do the blastocyst transfer 7 days later. Because if you give your injection of HCG, and you give it at night, it is as if you do the so-called virtual oocyte retrieval 2 days later, and then 5 days later blastocyst. So 7 days after having injected the HCG trigger, you can transfer your blastocyst. If you do a day 3 embryo, and not like we do, you thaw on day 3 and you transfer on day 4, but if you thaw on day 3 and you transfer on day 3, then you do your embryo transfer 5 days after HCG trigger. However, if you await a spontaneous LH peak, more than 180% compared with the previous value, then you do in a day 3 embryo that you transfer day 3, you do LH plus 4. When you do the blastocyst, you do LH plus 6. All this has been very nicely written in a review paper by Shari Makkens from our group in Human Reproduction Update. So it would be interesting to look at this paper, giving you an overview about the different methods for preparation and timing of the frozen embryo transfer. So if I can come to the conclusion, obviously, and you are a very nice example for that, frozen embryo transfers are actually getting more important than the fresh embryo transfers. There is still controversy with regard to the best protocol, but obviously, if more and more data are coming about hypertensive disorders, preeclampsia and eclampsia, for the HRT cycle, we should be careful and maybe go back to the modified or complete natural cycle. But ladies and gentlemen, we need RCTs. We need to make comparisons. We need to choose for the best protocol based on very well randomized controlled trials. Thank you so much.
Thank you, Dr. Christophe. Thanks for such an, precise and accurate and elaborate session on this topic, which is new to us. And many questions are there, which I would take one by one. And dear doctors, in case you want to ask, please write in the please send your queries to me. A doctor has asked, what precautions for natural cycle FET needs to be taken? Precautions.
Sorry, what? Yeah.
They want to know, suppose you have called up a patient. How do you minimize the chances that a patient goes back? Goes back home and comes next month because her endometrial thickness is not fairly good in a natural cycle FET. What precautions do you take? What measures do you take to avoid such an incident?
Well, actually, with regard to the endometrium, if we plan a natural cycle, and the endometrium is really thin, then we will still switch to an artificially prepared cycle and see if this is better. For us, but this is not the case in many other countries, for us, the third choice will be the stimulated cycle. That is the third choice. And the reason why is just because of the cost, because the cost of FSH in Belgium is expensive. I know centers who use the FSH stimulation for endometrial reasons to enhance the thickness of the endometrium as a first or second choice. So you can certainly administer FSH, and I would also say from day 6 of the stimulation onwards, or from day 6 of the cycle onwards, to see what is happening and what is going on. Of course, a thin endometrium requires, first of all, a good workup. We need to do a hysteroscopy. We do need to do an endometrial biopsy and so on before, of course, we can start with a frozen embryo transfer in case of a thin endometrium.
Okay, and what do you suggest regarding letrozole and clomiphene use in these kind of cycles?
Well, this is a very important question because you in India, you have a lot of experience with the letrozole, more than we have in Europe, because since it was off-label, we were not allowed to use it. We are actually now planning a randomized trial, and we are planning letrozole versus HRT. So letrozole natural cycle versus HRT, because the clomiphene that we use sometimes had a bad impact on the endometrium, which we do not see with the letrozole. So I'm actually very keen on the use of letrozole in a frozen embryo transfer cycle. The only issue is that the data are lacking. So again, for you, an invitation, please, since you have so much experience with letrozole, prescribe it to your patients, or maybe do a study, true natural cycle versus letrozole modified natural cycle, and look into endometrial thickness, so secondary outcomes, endometrial thickness, endocrine profile, length of the follicular phase, and so on, and then looking into the implantation and the clinical pregnancy rates would be extremely nice.
Okay. And what do you suggest regarding estrogen and progesterone supplements after embryo transfers in modified natural cycles? Like you have given HCG, and then two also you will supplement estrogen, progesterone. What dosages you would prefer? How long you want to continue them?
Yes. Well, first of all, with regard to the administration of estradiol, there is no evidence. So we stopped doing that because the results were exactly the same. So the estradiol that you give in the luteal phase following a natural cycle makes no sense. So I would not prescribe estradiol, nor micronized estradiol, nor estradiol valerate. With regard to the progesterone, it is important to know that that progesterone should not be initiated too early. It's like in a natural cycle. Progesterone is climbing slowly, so please do not use the progesterone too early. And the general dosage will be 3 times 200 milligrams. But you know, this 3 times 200 milligrams of utrogestan, for example, or one time the micronized vaginal progesterone gel per day, or the oral dihydrogesterone 3 times daily. This is all based on good clinical practice and not on evidence-based medicine. You know that there is an extreme lack of dose finding studies with regard to the ideal dose of progesterone. So we give 200 and they give 400, and other people give 600 milligrams of vaginal progesterone, for example. What is mostly administered is the 600 milligrams, but actually I need to add that those finding studies are lacking.
Okay. Um, Then, in your vast experience regarding natural cycle FET, what is your experience or about the incidence of preeclampsia in these kind of patients?
Well, so it is too early to share some slides about it, because we will present it at ESHRE, if I recall well, on Tuesday. It's Dr. Roelens. I am the last author, and my younger colleague Roelens is the first author, and we show exactly the same as the previous data. So if I recall well by heart, it's a 5 or 10-fold higher preeclampsia in HRT cycles as compared with the natural cycle. We practically see no difference between spontaneous pregnancies and fed natural cycle pregnancies with regard to preeclampsia. So extremely interesting data that will come out of this.
Okay. And how do you monitor your natural cycle? I mean, what all endocrine parameters do you take into account?
Yes, interesting question. So we always start by performing an endocrine profile on day 2 or day 3 of the cycle, just to see whether the patient is completely basal with regard to E2 LH, because we need a basal LH, and also progesterone. So when we have progesterone, LH, and E2 in the beginning of the cycle, we also measure FSH, but this is maybe less important. So when we have a nice endocrine profile on day 2 of the cycle, then we ask them to come on day 11 or day 12, depending depending on the endocrine profile in the beginning. But normally between day 11 and day 13, we ask them to come for a second endocrine profile, where we observe indeed again LH, E2, and progesterone. And then when the patient is scheduled for an ATG triggered regimen, ATG can be given because we always combine the endocrine monitoring with the ultrasound on day 12. And then based on that, we give ATG, or we continue only with blood samples every 2 days, endocrine profile, progesterone and LH every 2 days, to see when she ovulated, when the LH peak occurs or occurred, and then we count when we can do the frozen embryo transfer. Was that clear?
I think people are confused because you just said that when you are giving HCG, so you are doing a day 5 blastocyst transfer 7 days later than that.
Yes.
Right. So maybe that's why they want to know, suppose in a natural cycle, absolutely no modified natural, only natural cycle, when you are
Yes.
monitoring a lady on second day of her period, suppose she has come to you, you have done a baseline ultrasound, and then as you just said that you would like to do estrogen, progesterone and LH, and then you probably will call her on day 11 or 12.
Yes.
So then they want to know what all you want to do on that particular day. Now that you have sent that lady, suppose on 11th day, and you have called her on 13th day.
So we call them on the 13th day, and
Or
probably.
you will, sorry to interrupt you. The question was like that, suppose what size of the follicle you will choose, that then this is the time I should call this lady daily for ultrasound monitorings. Reason being, suppose you have called a lady on 11th day, the follicle was 17 mm. So if you are expecting that, okay, it will grow by 17, not 17, 16 mm, then you call that lady, okay, now from 11th day, you come directly on 13th day.
Yes.
And that day the follicle is ruptured. So you
Yes.
don't know whether it ruptured on 13th day morning or 12th day evening or 12th morning.
Yes. But
So,
there I think we need to know that
mhm.
the window of implantation is broader and is probably 72 hours and not 12 or 24 hours. So I think, dear colleague, when we do a first endocrine monitoring plus ultrasound on day 12, and then we continue to do endocrine monitoring only every 2 days, that with a very good specificity, we can schedule and see when the LH has occurred. So there, we don't have problems with that, and we do this on a daily basis, many times, and with very good results. And you know, this brings me back to the to a previous study that was in HRT cycles, where we did the transfer 5 days versus 7 days later. I could show you maybe a slide later or now.
Mhm.
5 days versus 7 days, and that also give quite similar results. Yes, let me share the screen 2 minutes. Sorry.
Mm, right, that's right. But what the question probably is that then which day you will do the transfer? You have called a lady on 11th day, then you have called her on 13th day. The follicle
Yes,
is
yes,
ruptured now,
yeah.
and you have a blastocyst frozen with you. So, suppose on 11th of April you have called,
Yes,
then you have called her on 13th April, and the follicle is ruptured. So, will you do transfer in that particular cycle, or
of course, of course.
okay? Then how do you calculate that from 13th April onwards? Now, when should I do the
So
blastocyst transfer?
first of all, if the endometrium on the 11th of April,
Mm-hmm.
which is day 11,
Mm-hmm.
on the 11th of April, her endometrium was 8 millimeters. She
Mm-hmm.
had a follicle of 17 millimeters or 16 mm.
Mm-hmm.
And then 2 days later, we do a blood sample.
Mm-hmm.
And we see that the progesterone, for example, I have nice cases of that, but yeah, if the progesterone, for example, from day 11 to day 13 went from 0.9 to 1.4, and the LH is probably went from 20 to 60 again to 20, then we know that she ovulated on the 12th, for example.
Mm-hmm.
Is that clear for you?
Yeah, I'm getting your point. That's why we are asking you that which one will be better, doing a absolute natural cycle or a modified natural, because then you
Well,
are
based on the new results that we have, a modified natural cycle will have the same results, will make life much easier, and will give you a better way to schedule and to plan. So I think that modified natural cycle deserves certainly its place, and I think this is the way to proceed. So I fully agree with that.
okay. Then do how do you decide that when should I give the HCG trigger? Is it on the follicle size, or then you do color Doppler of the follicles, look for the PSV, RI, and all? How do you decide to give HCG trigger?
Well, if the endocrine profile is okay, which means a nice estradiol, basal LH, basal LH, because you cannot combine an increased LH level, so in the beginning of an ovulation together with HCG. This has been proven to give very low outcomes, so please don't do that. So if the E2 is acceptable, 160, 220 nanogram per ml. If the LH is low and if the progesterone is low, if the endometrium is fine, and if the follicle is 15, 16, 17, 18, 19 mm, you can give HCG. You can give HCG and plan your frozen embryo transfer in case of a blastocyst 7 days later without any problem. And we have pregnancy rates between 45 and 50% in our natural cycle blastocyst embryo transfers now. So that's
So
quite
you
okay.
don't look for an rupture of follicle or not? If you give HCG
No,
trigger, don't you call a patient to see if she has her follicle ruptured or not?
no, we did that in the past, but since we had so many, let's say, false negative patients, we stopped that because it is one visit more for the patients. So we stopped doing so.
Okay, so we can conclude something like that, that once you have called the patient on day 12, you are doing daily endocrine monitoring of the patient.
Every 2 days.
Every 2 days, okay.
Yeah.
And then you are doing either a natural cycle, or then you are deciding to give your HCG trigger and then just do embryo transfer on 7th day of HCG
Exactly.
without checking the follicle has ruptured or not.
Exactly. Exactly.
Okay.
What we are planning to do, and this again is based on the HRT cycles, is to measure the progesterone on the day of embryo transfer. Because you know from Labarta from 2017 that in case of low progesterone on the day of embryo transfer, that pregnancy rates will be low. But this is only in HRT cycles. We don't have these data in natural or modified natural cycles. So we could also start measuring progesterone on the day of embryo transfer following a modified natural cycle. So let's see what that tells us, what that gives us, and then draw conclusions. But up until now, we did not measure or we did not do an endocrine profile after the injection of HCG.
So what is the right endocrine profile you would suggest? Then this is the right time to give HCG.
Well, if the LH is less than 10, if the progesterone is less than 1.5, if the E2 is 120 or 200, this is a very nice endocrine profile. You know that the endocrine profile as such is not completely predictive for the outcome. So I would prefer a good scan, ultrasound scan with a nice endometrium, of course, rather than an E2 value of above such value, because of course, there is no evidence about what is the optimal basal level of E2 and what is the optimal level of E2 prior to ovulation. There is no evidence on that.
Actually, people are finding it a little bit difficult and confusing to decide how to, monitor the cycle. That's why they're asking the same question again.
Okay.
One of the, doctor is asking that some patient may be having allergy to all forms of gestone, so they tried natural cycle transfer in the patient, and they had used letrozole triggered with HCG, and they transferred the 7th day blastocyst, but it failed. So they were asking, ki, repeating the same, we always found uh, serum progesterone low even after adding dufaston. I mean, after giving trigger and transfer, do we need to monitor the progesterone levels? I think something like that only he wants to ask.
So as I told you, so measuring progesterone after an HCG triggered modified natural cycle, today I cannot tell you that we should do it because there is no evidence. There's not a real need for that today. So measuring progesterone on the day of embryo transfer or the day before embryo transfer still has no evidence today whether it is important, yes or no. So I would not let the patient come to the clinic if there is really no evidence that that this would help. Is that clear?
Yeah, I think.
In the meantime, I'm looking for a case of a frozen embryo transfer cycle prepared in a natural cycle.
Okay,
And
this.
you, uh,
I'll wait. You just take your time to find out the case. I
yes,
think lot
that
many
would
will
be
be helped with
really
it.
interesting.
Yes, I'll just wait for that.
Um, Just a second, please. Let me check it out for you. Okay, so let me show you a case of insemination. I don't find immediately a case.
Okay.
But it's more or less the same with the frozen embryo transfer as with regard to insemination. The only thing with the insemination is, of course, that we do a daily blood sample.
Okay.
Let me share the screen now. Let me. Do you see my screen now?
Yes.
Okay. So in this patient, so we did not do any endocrine profile in the beginning. So we started on day 11. So you can see here, do you see my arrow?
Yeah.
Yeah. So on day 11, we did an endocrine profile, and this patient has a high basal LH. So this is LH, this is E2, this is progesterone and FSH. So as you can see, the basal LH is high, then 91 of E2 nanogram per liter, and then the progesterone is basal. So we let her come 2 days later, and then we see that the E2 is 168. We let her come 2 days later. We see that that the estrogens are 300 and so on. And then we let her come on the daily base. So we see that when we let her come on the daily base, you see here that the progesterone is 0.9, that the LH is 67. So this is obviously the day of ovulation. So that means that the oocyte retrieval would take place on the 11th of March. And then we do the blastocyst transfer, 1, 2, 3, 4, 5. So plus on this day. Because it's as if we do the oocyte retrieval here on the 11th of March. You can see clearly that the LH is the blue line, is quite high in basal circumstances because it was a PCOS patient, but a PCOM morphology. And then we have the LH peak. We see the estradiol that is going high and then going down a bit. So well, here it is an insemination, but do you agree that the frozen embryo transfer should take place on the 16th of March? We do the virtual oocyte retrieval on the 11th.
Yes. So
And then
that can be taken as day 0.
So this is 1, yes, exactly. 2, 3, 4, sorry, 3, 4. And on the 5th day, the blastocyst transfer will take place. Here you see EOK, EOK. So we did 2 ultrasound scans, and afterwards we didn't do any more ultrasound scans. So this is echo, is ultrasound. We did not do any ultrasounds because then the endometrium was fine. So we did not need to check anymore. We just did endocrine monitoring to look here. Is that clear for you?
I think this chart has made a lot of questions answered. But still, people are over and again asking for the same thing. Suppose on day 2, if the LH is high, then should it be, influencing our interpretation of hormonal profile?
Yes. So of course you have your level of AMH to start with, and you have a level of AMH. But if, for example, your FSH is 9, if your progesterone is 0.5, if the estradiol is 36, then regardless of the LH, this has also been studied. If your LH is 4, if your LH is 8, or if your LH is 12, then she is still basal. It is just because she has an elevated basal level of LH. So you can easily proceed and go to day 11. So this is day 2. This is day 2. You can easily proceed with with your cycle.
So day 2 LH, we can say, doesn't hold any much significance.
Exactly. LH in the beginning of the cycle is less important, but of course, it gives us an idea about the basal levels. If here the basal level would be 1, then this level of 14 would be extremely bizarre. So then you can assume that you would have a beginning of an ovulation. If the basal level is 12, then of course there is no increase here. Do you see that?
Yeah. Okay. Uh, Our doctor is asking that in hormonal replaced hormonal prepared FET cycles, we are adding aspirin.
Hmm.
So if we are doing natural cycles and or if we do hormonal replaced FET cycles along with aspirin, so will it help in reducing the PIH chances in the ladies exposed to hormone replacement therapy?
Well, actually, with regard to the aspirin administration in HRT cycles, we are performing it, especially in recipients. So after oocyte donation cycles. So I think there is certainly a place of adding aspirin, although we need to be cautious with the studies. The last recommendations coming from the UK is that we actually should give it the aspirin, but to circumvent the whole story and the lack of relaxing and so on is another thing. So I think that I certainly am a pro aspirin, and probably until 11 weeks of gestation. But if this will help us completely to have less hypertensive disorders is still an open question. But the question is very accurate.
Okay, and how much gap would you advocate for a natural cycle FET after ovum pickup?
Come again, please.
Suppose we have done ovum pickup in the month of March. So how earliest we can take the patient for natural cycle FET?
After an IVF cycle.
Yeah, I have done a ovum pickup in March.
But there is no problem. I showed you the slides. I showed you the slides that we can go to an immediate frozen transfer after a stimulated cycle. There is no need to delay. There is no need to wait one more cycle. There is no need to let the ovaries rest. I have shown this clearly in the presentation that we should not delay. No problem at all.
Okay, and a doctor wants to know if there is any role of fresh transfers in present day scenario, I mean, present ART cycles.
Well, we still do, as I told you in the beginning, we still do 70% of fresh embryo transfers and 30% of freeze-all strategy for reasons of PGT, of OHSS, of progesterone elevation. But of course, there is certainly still a place for the fresh embryo transfer. You need to know that in Europe, only 5 to 10% of the cycles are freeze-all cycles. So the vast majority of the cycles are still fresh embryo transfers, yes.
Okay, and what is the level of LH you would like to have on the day of HCG trigger on in modified natural cycles?
The level of
LH on the day of
LH,
HCG trigger, yeah.
well, it should be more than
80
80%.
times, yeah. Okay.
Yes, yes. But what we normally use as a cutoff for an LH elevation is 20. Of course, again, depending on the basal level of LH, because regardless of the importance of the LH in the beginning, we need to have it. Because if your basal LH is 15, for example, then you cannot say that 20 of LH is an LH peak. But normally we take between 18 and 20 as LH peak in normal responder patients.
And 180 times, I mean, compared to the day 2 level, in case basal LH is already high.
Yeah, the same is true there.
Okay.
180%, not 180 times. It's 180%.
Sir, a doctor has asked a practical question in our scenario, I mean, in Indra practicing. She is asking, suppose I have given HCG to a lady in modified natural cycle and I have called her to see whether the follicle has ruptured or not.
Yes.
And she is able to see a cyst instead of a corpus luteum.
Yes, then
So,
I would certainly, sorry.
yeah, you can.
I would certainly do an endocrine profile to see if the progesterone is high, to see if she ovulated. If there is a cyst, then there is no problem. We can proceed with the embryo transfer in safe circumstances.
Okay, if the progesterone is more than 1.5, then even with the presence of a cyst, you will go ahead.
Sorry, the presence of?
So in the presence of cyst, if the progesterone is more than 1.5, then you will go ahead.
Yes, we can go ahead because in the vast majority of the cases, a cyst will not hinder implantation and will not cause any problems.
So you personally are adding progesterone after transfer, or
Well, yes. Well, so after the bad results that we have when starting too early, we are now administering progesterone from the day of embryo transfer onwards.
how long you are continuing that?
Sorry?
How long are you giving the progesterone, and what progesterone you are using?
Well, we are still using today micronized vaginal progesterone 3 times per day, 200 milligrams. So 600 milligrams in total. And and that is, of course, the most difficult questions. When should we stop giving the luteal phase support? Well, actually, as soon as the HCG levels are present, we can stop the administration of progesterone. But of course, we give it a bit longer. We apply a non-evidence-based approach, and we give it until 7 weeks of gestation. Again, we are talking about a natural cycle or modified natural cycle. And then we give it until 7 weeks of gestation.
Okay, and the other doctor has raised a question that shouldn't we be doing a progesterone on the day of embryo transfer?
Well, well, again, there, I would say yes, but so what? If we do it in an artificially prepared frozen embryo transfer cycle, then we know that a level below 9.2 is important because if it gives worse outcome. In a modified or in a natural cycle, we don't know what the cutoff is of a progesterone level to draw conclusions, to give a more progesterone and so on. So what we do is now we give it in a generalized way. We give progesterone without measuring the blood, but maybe we should do it.
Okay, and how do you go ahead with your patients who are severe PCOS or are having irregular cycles? So natural cycle or
Possible. Natural cycle will be impossible. We can use letrozole as a first step. If the letrozole really with the severe PCOS patients does not help, then we do still do an HRT cycle, and FET HRT cycle.
Mhm. Okay. Uh, just I had projected a question where there was a cyst formation with progesterone. If you have checked, it is more than 1.5. But suppose the same patient, after giving HCG trigger, we see a cyst, and when we do a progesterone, it is less than 1.5.
And
Then
then
should we transfer or we should withhold it?
no, we should not transfer. Since she did not ovulate and she developed a cyst, I would cancel the embryo transfer and move her and or make her ovulate or wait 1 month.
Okay, so I to summarize, I can say the whole lot of doctors have two common queries in their mind. One is like uh, uh, what should be the parameter to decide that this is the right time to give HCG. One aspect is ultrasound monitoring of the follicle versus the endocrine monitoring, what you are suggesting. So,
Yes.
uh, I think one question is this, which is again and over again coming to us, that whether which endocrine profile we should proceed and what are all the ultrasound parameters we should consider to give HCG in modified natural cycle.
So, so the clear answer that you want from me, when do we give HCG in a modified natural cycle for frozen embryo transfer,
Yeah.
is based on the ultrasound. If the endometrium is fine, if the follicle is mature between 16 and 22 mm's without progesterone change, then you give HCG. This is clear.
Okay.
If, however, the progesterone has increased already, if the progesterone, if the DLH shows an ovulation, then it is different, of course. Then you don't give HCG anymore. But HCG is given in optimal circumstances when endometrium is acceptable, more than 7 millimeters. If your follicle reaches the stage of maturity, and if the hormonal blood shows that no ovulation is occurring. Then you give your HCG.
Okay. So you suggest that after 10th or 11th day, we should have a chart, something what you just shown, you showed to us,
Yes.
a patient who underwent an
Yes.
insemination.
We usually do the first scan on day 12. Day 11 is a bit early, maybe. We usually scan on day 12 together with an endocrine profile, and then we decide. Yes.
And then every alternate day you call the patient.
Exactly. Well, we actually always let the patients come in the morning. So between 8 and 12, we have the ultrasound session, and then we call them in the afternoon when we have the results of the blood. The blood results are taking 2 hours. So after 2 hours, we have the results. So we call the patients always in the afternoon, not the day later.
No, no, no. I'm asking that you have called a patient on day 12 of her periods.
Yes.
and you do an ultrasound, send the blood investigation, the endocrine profile, and then you call the lady in the same on the same afternoon.
That she can give her ACG, that she can inject the ACG injection, and that she can come for a transfer 1 week later. Yes.
Okay, but if I'm talking about the monitoring part of it, so I want you to summarize for us so that everybody has the same take home message, that you
Yes.
call the lady on day 12 of period,
Yes. Exactly.
you do an ultrasound,
So the
then sorry, you tell. Sorry,
so
sorry.
sorry, no,
No,
no.
I was just completing the question that then alternate days you keep doing the endocrine profile till.
Until when we see that LH or and progesterone has increased. If we see that progesterone every 2 days remains the same, and after 2 days is suddenly 2.2, then we know she ovulated. If we see that the progesterone remains the same, but that LH suddenly increased, then we see she's ovulating.
Right. So you make a chart as you has just showed, and then you interpret. So how do you take into account for the day you have not done an endocrine profile for that lady? So according to the graph, you will calculate when she had that.
Exactly. We can always make an assumption. If we see that LH does not move, but that progesterone went from zero point 0.9 to 2, then it's obvious that she ovulated in the day that we did not perform a blood sample.
Yes.
So that's easy. Listen, next time I need to show you some nice cases of frozen embryo transfer. I have so many nice cases of how we do it in our daily practice by not taking blood every day, but every 2 days, and how we are well showing of ovulation or non-ovulation.
Oh,
It's
that would be very, that would be great because we actually are into this, that we are doing almost freeze all embryo transfers in our setup. And if we are able to do natural cycle or modify natural cycle, it will be a great help to us.
yes, okay, I will.
So I think we will schedule another session for that. Like you can give us some ideas about with the evident case, scenarios in front of you,
Okay.
as you had just shown us. So, sir, can we start vaginal progesterone in gradually increasing manner immediately after trigger and continue after transfer so that we don't have low progesterone on the day of transfer?
Yeah, I think this makes sense. I think that we could certainly do that. You know, we have 5,000 cycles per year, and we need to work in strategies. So this is why we do it on the day of transfer. But I think that if we want to mimic the natural cycle in a complete correct way, that it makes sense to do the gradually step up progesterone before the frozen embryo transfer. I fully agree with that.
Yeah, as it happens in natural cycle by day 21 when the blastocyst implants, that is the time when the highest progesterone level is seen.
Exactly.
Yeah. So patients with thick endometrium say day 10 is more than 12 millimeters, but the follicle is still less than 16. So do we wait for the follicle size to grow or
Yeah,
we give any?
in that case, I would repeat an ultrasound after 2 days.
So the follicle size is more pertinent rather than the endometrial thickness.
Yes.
So
Yes.
generally, up to what endometrial thickness? Because sometimes even with like good endometrium, good follicular size, the endometrium is seen up to 16, 17 mm. So
Mhm.
is that fine for a natural cycle if somebody is having a thick endometrium?
Well, of course, in these cases, it would be extremely interesting to see the ultrasound scan in basal circumstances as well, or previous ultrasounds. Did she have also a very thick endometrium? Is this an old finding that we have? Does the patient maybe always produces an endometrium of 5 to 10 millimeters, and now suddenly it is 15 or 18, the 18 millimeters? In that case, of course, we should suspect that an endometrial polyp could be an issue. So we need to do a 3D or an let's say a Doppler or a hysteroscopy
Hysteroscopy.
also, and see what is
But
going on.
there are few ladies who always have a thick endometrium, around 14, 15, 16.
In that case, we proceed. No problem at all.
Up to how much of endometrium? Up to 18 also?
Well, I should check the publication of Liu from Canada again, showing that that pregnancy rates are going down as soon as you have a lower endometrium than 7 millimeters. But Liu also showed showed that at a certain upper limit that there is also a problem. And I am looking at the paper now. No, there's not really an upper limit.
Fine. Thank you so much, Dr. Christophe. I think the doctors have exhausted their questions. So thanks for the day today, I believe. But we'll be really looking forward for those case scenarios where, how you have monitored your patients and all.
Okay, that would be exactly very interesting also to share that.
Yeah. And I convey my sincere thanks to you now because, initially I was a little bit in panic because I was getting all the calls from the help team, from the, people who were organizing this and they had some problem. They are not able to get into the participants and all. So that the session starting was quite anxious for me. But I really like I mean we all must have been helped a lot by your kind guidance and throwing light into this aspect which is a new aspect for all of us. Thank you so much.
Thank you. See you soon. Bye bye.
Bye
Bye.
sir.